So this is another really good question that which of the following approved anti-diabetic drugs be given in heart failure with a reduced ejection fraction and impaired renal function. So it is asking about HFrEF and decreased renal function. So the answer to this question is gliflozins. Why? Because gliflozins are now proven to have cardioprotective as well as renoprotective properties. Now we won't stop at this. I will teach you all the diabetic drugs that are to be given in decreased renal function and drugs which are given in heart failure with reduced ejection fraction. So first of all, the important thing about decreased renal function is that the safest choices in renal failure are insulin, glipizide. Among sulfonylureas, if you want to give one drug, then it would be glipizide, and linagliptin. Linagliptin is very important among DPP4 inhibitors. In means inhibitor, so DPP4 inhibitor, linagliptin, and pioglitazone. Pioglitazone specifically if no heart failure. Pioglitazone can't be given when heart failure is there. I will teach you that. So renal failure safe choices are insulin, glipizide, linagliptin, pioglitazone. Now you may ask that this list does not contain sulfonylurea. So the thing, this list does not contain SGLT2 inhibitors. So think about SGLT2 inhibitors in CKD is that SGLT2 inhibitors, they decrease glucose by how? They decrease glucose by losing glucose in the urine. Now in CKD, urine itself is not being produced. So you may think that how will SGLT2 inhibitors be helpful in a patient with CKD? Right, because urine is not being produced and glucose was to be lost in the urine. So SGLT2 inhibitors should not help. But what happens is that SGLT2 inhibitors have independent cardioprotective and renoprotective properties. So in CKD patients, you do give SGLT2 inhibitors. Why you do give SGLT2 inhibitors? Not for sugar control, not for sugar control, but for renoprotective and cardioprotective properties. So you may ask that a CKD patient, why are we talking about cardioprotective properties? Why? Because the main cause of mortality in a CKD patient is what? The leading cause of mortality in a CKD patient is cardiovascular causes. So we have to protect the heart as well. So SGLT2 inhibitor drugs, these are used in CKD patients not to reduce the sugar level but for their renoprotective and cardioprotective properties. Next, coming to heart failure. So heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, SGLT2 inhibitors are now approved in both of them. So SGLT2 inhibitors are now given in HFrEF and also a quantity known as HFpEF. So also in context to heart failure, you have to remember that heart failure has these four drugs which are known to reduce mortality. So only these four drugs classes are known to reduce mortality among all the drugs which are available. So first one is ARNI, then beta blocker, SGLT2 inhibitors, and mineralocorticoid receptor antagonist, spironolactone. Example, spironolactone. Now ARNI, you may also give ACE inhibitor and ARB, but ARNI if given in the options is a better choice than ACE inhibitor or ARB, but ACE inhibitor or ARB also do decrease mortality. However, ARNI has the maximum mortality benefit out of these. Then among heart failure patients, you have to avoid glitazones. Because why? Because glitazone drugs, they cause fluid retention. So say for example pioglitazone, you do not give in heart failure. Another important side effect of glitazones we can revise here is bladder cancer. So bladder cancer. So that's why these drugs are out of favor in heart failure or otherwise also now these are given less because of the risk of bladder cancer. Now just seeing the explanation once, because it contains the name of two trials. So these are the two trials, Emperor reduced and EMPA kidney. So this demonstrated the importance of SGLT2 inhibitors in HFrEF and CKD. These trial names are not for MD level entrances, but still you can see.